information.
Okay, let's go ahead and start. Welcome, everyone. I'm glad to be with you again.
Yes.
Last month in person, and now this month on Zoom. So, tell us about this first case, uh, Dr. Lin.
The tumor at the patient is male, 41 years old, and the tumor in the circum.
Okay,
Uh, it look like polyp and about 2 centimeter diameter.
okay. So, a polypoid lesion, and the patient must have some symptoms, maybe. How did they discover the tumor? Do you know? Was the patient bleeding or having pain? Maybe a little obstructive symptoms or something like that. You sent us this section, and we can see the colonic mucosa here, muscularis mucosa, and then sort of a deeper tumor out in the muscle. Um, Not very blue, mostly pink. A few inflammatory cells here and there, and not involving the upper overlying mucosa at all. So that's an interesting finding. It seems to be centered in the muscle. And as we look at the tumor, we can see that it has sort of a nesting pattern, sort of rounded balls of cells, quite a lot of cytoplasm to these balls of tumor cells, and the nuclei are not very atypical, not pleomorphic. And we can see the cytoplasm is very granular, very pink, but has a granular character to it. So it's very natural that we would consider something like a granular cell tumor. This, for example, this cell right here has a strikingly granular cytoplasm. Um, and that diagnosis is probably the most likely diagnosis with this sort of cytoplasmic appearance. But there are other things that can have sort of a cell ball type of appearance, sometimes smooth muscle tumors, sometimes paraganglial tumors, um, some neuroendocrine tumors of other types, although they would usually not have such abundant cytoplasm. Um, Coming back here, I think we can look at some of the higher magnification views that you sent along with this. Here's a nice high magnification view that shows these very small nuclei and very granular, abundant cytoplasm to the cells. Another view, large nests of tumor cells. And here a little bit more um, striking granularity. This almost looks like it could be a PAS stain. The PAS stain should highlight these granules if you're able to do that. But it's obviously not essential. Although when I was training, that was the normal first stain to do. And here we see again these large nests of tumor cells with intervening kind of spindly uh, fibrous tissue and some areas of inflammation. Now, schwannomas can oftentimes have a cuff of lymphocytes like this. And so that would also be in the differential. Oops, where are we here? I think we're down here. So then we start to get into the immunohistochemistry, and one of the first ones you did was SOX10, which is a good stain, a nuclear stain, very fairly specific for neurogenic derivation. And here we see that it is a nice specific nuclear stain, mostly in these cells with the granular cytoplasm and not in the intervening spindle-shaped fibroblastic component. So that's very helpful that this is a specific staining in the tumor. And here we see that again. Then an S100 stain. Of course, S100, as we used to say, stains 100 things. But in this context, this is very helpful. And this staining pattern is one of the reasons why initially we thought that granular cell tumor was a nerve-derived tumor because of this commonality with Schwann cell tumors and so forth. Fairly strong cytoplasmic staining, not so much nuclear staining. And here we see it again in the tumor cells, not the intervening fibrous stroma. Of course, we know that S100 will stain dendritic cells and various other cells as well. Desmond stain nicely excludes smooth muscle derivation. I suppose a low power view would have been helpful to see whether or not there was intervening muscle between the tumor cells. Now, the CD34 stain, I suspect you were considering the possibility of solitary fibrous tumor or something of that sort, which might also be in the differential. And that's obviously negative, except in the vessels. Calretinin, likewise for mesothelial derived or some sex cord stromal tumors, and so forth. So that's pretty much the extent of staining. And I think the differential consideration in this situation is first off, granular cell tumor. But there's one other tumor that can have a nested arrangement, can have fairly abundant cytoplasm, and can have SOX10 and S100 positivity, negative for other markers, and that is a paraganglioma. So because this is an unusual location for either of those tumors, it might be worth considering. However, in terms of management and prognosis, probably there's very little difference in outcome now that that tumor has been resected. So spending that additional money to say it's definitely not paraganglioma is probably in most situations not money well spent because it's not going to add too much to the value of your diagnosis. So that's kind of my evaluation is that this is a likely a granular cell tumor, but we can't totally exclude a paraganglioma. I suppose in that setting, it would be good to ask the question of, does this patient have any of the stigmata of a multiple endocrine neoplasia syndrome, where a paraganglioma might be a higher consideration? And if so, if you're going to do the stain to exclude that, that would be the main reason to exclude the possibility that this may be part of multiple endocrine neoplasia syndrome, and therefore potentially heritable for other family members as well. Anybody have any questions or comments about that appraisal? Granular cell tumor is relatively uncommon in the tubular tract. Certainly below the esophagus, we only very, very rarely see it. I think this is only the second case I've seen in 10 years. But in the esophagus, we see it more frequently, and certainly in the tongue, it is a very commonly identified tumor. It can also occur in the skin and in a few other sites, but the most common site is the tip of the tongue, esophagus, and skin.
Professor, uh, for the diagnosis exactly granular cell tumor, I need to stain with other marker.
So I think the marker that would help to exclude paraganglioma would be synaptophysin. So if you have synaptophysin positivity, it would be more likely that this is a paraganglioma. If it's synaptophysin negative, then I think you can be confident 99% that this is granular cell tumor.
Yes, thank you. Because of my department out of the CD 68, how about CD 68 to useful for diagnosis? CD 68.
I don't usually use that with this differential. I mean, I suppose if you were considering a histiocyte type of lesion, you could do it. But since you have already SOX10 positive and S100 positive, I don't think CD68 is going to add any value.
Thank you.
Yes,
Thank
good
you.
questions. Good questions. So let me share a couple of cases that I would like to maybe have you consider. Um, let's see. All right, so we'll share my screen, and I'm going to pull up um, a couple of interesting cases that I shared with our residents this past week that illustrate some of the challenges with mesenchymal tumors in the uterus and in the peritoneal pelvic area. This is an area of challenging lesions. And so this first one is a myometrial mass or set of masses in a 45-year-old woman, I believe, who was having a hysterectomy for mild uterine enlargement and no other symptoms. But on examination, as you can see here, we have several nodules. Here's one, this one. Then we have some little nests of tumor cells here, this nodule, and this nodule. And so a multiple nodule type of lesion raises the question, are these just smooth muscle tumors that are quite cellular? Or could this be an endometrial stromal neoplasm? So we'll take a look at several of these areas because they seem to have somewhat different morphologies. So here we come to higher magnification, and as you can see, we have sort of a spindled pattern with clusters or cords of spindle-shaped cells. As you can see here, sort of streaming nuclei. But they're not particularly atypical. The nuclear features are fairly low grade. And we'll put this down here so we get more. So my initial reaction looking at this would be, well, this, because of the spindly appearance, this looks like a smooth muscle tumor. So that's one thing I'm thinking about there. But smooth muscle tumors don't usually have this kind of an appearance that we see over here, where they tend to dissect a little bit between the smooth muscle and in the sort of worm-like pattern. This would be somewhat unusual for most types of smooth muscle tumor. There is an intravascular leiomyomatosis that could look something like this, and sometimes is called sort of a worm-like process. But this raises consideration of this pattern of growth that we're dealing with an endometrial stromal sarcoma. So we'll look at this other area here. And again, here we have this sort of fascicle type growth, but very bland cytology, slightly larger nuclei, but not really atypical, and mitotic activity is quite low. So we've looked at several areas of this tumor. Now we'll come up and look at this area up here, which I think you can appreciate at low magnification has some of this spindle-shaped stuff, but may also have a different pattern here and a different pattern over here. So we'll take a look at these areas as well and see what's going on here. And in fact, as we the higher magnification here, we can see that this part of the tumor looks quite different from that other area. In fact, we have a sort of a corded and nested pattern, still with a bit of an infiltrative appearance in the background. But this looks quite different from that. So this actually, in a uterine tumor, I think, is sort of the sort of thing you see that looks a little bit like a sex cord stromal type element. So then we ask ourselves, all right, what are the tumors that we can see that have this sort of sex cord stromal type differentiation or pattern? Primarily, there are two tumors that you should be considering. Maybe a third on occasion. The main tumor to exclude is the uterine tumor resembling ovarian sex cord stromal tumor. And typically they abbreviate that into UTRSCOT, uterine tumor resembling ovarian sex cord stromal tumor, something of that sort. Anyway, the other tumor that can have these minor sex cord elements is the endometrial stromal sarcoma. And it's not really predictive as to which types of endometrial stromal sarcoma will have that. But the differential becomes interesting. Now, some people think that that the uterine tumor resembling ovarian sex cord stromal tumor is a variant of a leiomyoma, and sometimes then have considered that some leiomyomas can have this pattern, but I don't include that in this differential. The other area where we had a little bit of this pattern, I believe, was down here. Well, maybe I'm not seeing it here. So how do we work this up? This is a tumor where, of course, immunohistochemistry would be your first step. And I typically will do a CD10. I will do a progesterone receptor, a hormone receptor marker. In this case, we might do a sex cord stromal tumor marker like inhibin, calretinin, and so forth. Um, and then in some uterine sarcomas, we found it useful to do the cyclin D1 marker. That, however, is usually a marker for higher grade tumors, and in the low grade tumors, which would include this, I would not do that. So in this situation, then you would also include muscle markers like Desmond or Caldesmond or something of that sort. This tumor, interestingly, showed some areas which marked for Desmond. These sort of spindly areas around some of these areas had some Desmond positivity, and occasionally a little bit of positivity in the spindle cell component here, but it was quite strongly positive for CD10 and also for progestin. These sex cord elements will oftentimes stain for both sex cord markers and with CD10 as well. And then lastly, in more and more of our endometrial stromal tumors, we are asking for FISH testing, looking for a specific fusion gene that is present in almost all of the low-grade endometrial stromal sarcomas. And that's the JAS1 sus12 fusion gene partner. So if you don't have that, you can still make a presumptive diagnosis using the immunohistochemistry. So any questions or comments about that tumor with the sex cord stromal elements? Okay, well, let me share then another case. Um, uh, also a uterine tumor, but a somewhat unusual one. And this is one where we had no history of prior malignancy, but the patient presented with some fairly significant uterine enlargement and some bleeding that led to a hysterectomy. And here you see that we have a very blue, diffuse, patternless infiltrate that has some sort of irregular margins into the myometrium. And in fact, a lot of this pink tissue is kind of necrotic tissue. So this may not have even been myometrium, other than the fact that we see there are some vessels here that suggest that. It was a very fleshy mass, looked very kind of homogeneous and fractured very easily with these areas of necrosis. So looking a little more closely at this lesion, as you can see, it's fairly monotonous. There's high cellularity, high NC ratio. Seemingly there is separation between every cell. So that is a little bit unusual for most uterine tumors. They usually have some connectivity to each other, endometrial stromal sarcoma, as we've just indicated, and so forth. This looks to be a fairly high-grade tumor and has a little bit of granularity to some of the cytoplasm, as you see here. A few slightly eccentric granules and some nucleoli and so forth. So we took this as a high-grade neoplasm with a very diffuse pattern, and our differential included undifferentiated carcinoma. It included melanoma. It included lymphoma. And so we did some of those markers. Well, it was negative for melanocytic markers. It was negative for cytokeratin markers. And it was negative for T and B cell markers. There was no CD20, no CD3, no CD5. But we had some suggestion in some areas that there was CD45. So fortunately, we chose to do that stain. And then we were kind of wondering, well, what could this be? Well, the granularity to the cytoplasm was a clue. And so we decided to do a myeloperoxidase immunohistochemistry. And in fact, that marker was positive. And then we essentially had a diagnosis that we were dealing with what we call a granulocytic sarcoma, or a solid tissue mass of a um, acute leukemia. Um, in this case, the bone marrow was negative. This was the only identifiable location for this malignant neoplasm. And so that may govern the treatment for the patient. This is sometimes a blind spot, I think, for people who don't have a lot of training in hematopathology, because many laboratories don't have myeloperoxidase. And in a tumor that doesn't stain with anything, if you didn't remember to do CD45, or if you had only very weak expression or no expression of that marker in this case, as some granulocytic sarcomas may, you could be just left with undifferentiated high-grade malignant neoplasm. But fortunately, we got to the right diagnosis and rendered a diagnosis of granulocytic sarcoma in this patient. Any questions or comments about that? Have you seen anything like this in some of the solid organs that you deal with from time to time?
Professor, this tumor in uterus,
Yes, this was in the uterus. So that's a
and
very unusual site, but granulocytic sarcoma can occur in virtually any site. GI tract, GYN tract, skin, uh, trachea, other locations.
to diagnose malignant belong to morphic tumor, for example, necrosis or a high grade nuclear. Mm,
Yeah,
yeah.
so I think the key differential would be, is this lymphoma?
Uh,
Because that would be that would be more common. We do see lymphomas in the GYN tract, GI tract, and so forth. But those will usually have some sort of B or T cell marker that we can therefore pin it down as uh, lymphoma. But this lacked that situation, and so we had to resort to doing the myeloperoxidase exam. Okay, let's talk about another case here, um, and I think we'll do this case here. Um, so this is actually a young patient who is, I think she was in her teens, and this mass was involving the uh, pelvic floor and perineal areas. And it wasn't really clear what the anatomy was, but it was quite complicated. So the low power, we see a couple of things. We see a blue cell area. We see an area like here, sort of nodular. And then we've got this sort of fibrotic tissue as well. So we'll just sort of take it in that order, look at the fibrotic tissue here, and see that, we have some funny looking cells here. with a sort of eccentric nucleus and this very eosinophilic cytoplasm. So it looks kind of funky right there, but we do have a degree of pleomorphism in these areas. In this other area, we can see that we again have more of these cells, again with these nice eosinophilic inclusion bodies or the prominent eccentric eosinophilic inclusions in the uh, cytoplasm, maybe even a little bit hyper, sort of almost striated kind of appearance there in some of those areas. Um, and then we have these blue cell tumor or blue cell lesion, which is not just inflammatory cells. So we can see that they're very high grade cells. And we have this, again, some of this eccentric cytoplasm, a few sort of floret cells with peripheral nuclei. And very high grade appearance, poor vasculature, and so forth. So, how do we put this all together? Um, we have the atypical cells here with the eccentric nuclei. We have nests of them. And then we have this small blue cell lesion with the multinucleate and floret cells, and sometimes this slightly eccentric cytoplasm. Well, I think in a young patient, you're going to, of course, look at the differential for a small round blue cell tumor that includes things like neuroblastoma, rhabdomyosarcoma, Ewing sarcoma, and so forth. But with the presence of these more rhabdoid type of cells, um, both here in this nodule and then also out here in the surrounding tissues like here, I think this pushes us very significantly towards the diagnosis of a rhabdomyosarcoma. Now, you might ask or suggest and say, well, maybe these are just degenerated skeletal muscle fibers that have been destroyed by the presence of this tumor that's growing. Um, but I think we don't really have the kind of architecture that we would expect with sort of a degenerating skeletal muscle structure. So I don't think these have ever really formed into a functional skeletal muscle that is then atrophied, but rather I think these are part of the tumor as well. So putting that all together, this illustrates nicely one of the neoplasms that can occur in a variety of locations, but the GYN tract seems to be more common at times in the pediatric age group, that of a rhabdomyosarcoma. Now, what type would we venture to say? This may be a pleomorphic type because of the both small cell component and this more pleomorphic and nodular component that we see here. Now, I have one other case that I'd like to share that's sort of related to this lesion and represents a different manifestation or different scenario. So this is a slightly older patient, a 35-year-old patient. And this patient presented with abnormal bleeding and some uterine enlargement. On the initial biopsies of this tumor, we saw some features that immediately alerted us to the possibility, and that was that there were little islands of immature cartilaginous tissue, which you can see here. Well, maybe not right. Well, that is probably cartilaginous tissue, but very cellular. But then over here, you can see more of that morphology, this immature type of cartilage. And then surrounding that, we have, more of those nests, and we have this infiltrative pattern of a blue cell tumor, again, fairly small amounts of cytoplasm. So this raises the question of what kinds of tumors will present with a component of uh, uh, heterologous elements. So there should be, well, maybe 3 or 4 tumors that you think about as having potentially frequently encountered heterologous elements. And those would include carcinosarcomas, which can have cartilage or bone. Adenosarcomas can have heterologous elements. Wilms-like tumors can occasionally present in the uterus and can have heterologous elements. Teratomas not usually found within the uterine corpus, although obviously they could have heterologous elements. And then the fourth one is the embryonal rhabdomyosarcoma. And in fact, this is an example of that tumor where here is the embryonal musculature here. And then you see areas coming out of it that form cartilage or that look more myoid. So the stain that we use in this particular situation to sort of nail down myogenic differentiation is either myo D1 or myogenin. Other muscle markers like Desmond are not particularly helpful in this sort of a situation. Muscle actin is usually not helpful. You really need a more nuclear-based stain like myogenin or MyoD1 that defines the nuclear expression of those markers. In terms of age group, this is a fairly typical age for that presentation. It's usually younger women and so forth. Now, there's one other rhabdomyosarcoma, of course, that can occur usually in somewhat younger patients, and that's the botryoid rhabdomyosarcoma or pattern of rhabdomyosarcoma. I don't have a good example of that particular tumor type to share with you today. So any questions about those rhabdomyosarcomas? Okay, you're being very, very good listeners. We'll go on to one more interesting kind of case that I think is worth knowing about. Um, I'm going to presume that you know how to make the diagnosis of um, uh, leiomyoma and leiomyosarcoma. Those generally are fairly readily accomplished, although obviously there's some gray zones for the smooth muscle tumor of uncertain malignant potential and so forth. This lesion is again, looks like a large myoma, a leiomyoma type tumor. It's found in the uterine corpus. It's usually of a pretty good size. And as you can see, it's got sort of pinkish cytoplasm and so forth. As we look at this tumor with higher magnification, though, we may often discover that there's a degree of nuclear atypia in this lesion. We see some kind of very large multinucleate pattern cells. And so the diagnosis that we might first think of is, oh, is this a leiomyosarcoma? But in fact, as we looked at this tumor at low power, we don't see areas of necrosis. So we just have cytologic atypia and high cellularity. And then when we go looking for mitoses, we really don't find them in this lesion. So we only have cytologic atypia, as you can see here. And it's reasonably diffuse in this lesion, and uh, it's not, how would I say this? It's not extreme. There's some enlargement, there's some multinucleation, but it's not the most bizarre cells that you've ever seen. Um, and that's important because there are two tumors that fit into the category of smooth muscle tumors that can have bizarre atypical cells and no mitotic activity. And the first one is a tumor that we just call leiomyoma with bizarre nuclei. And those tumors can have abnormal staining results, but they have no mitoses, they have no necrosis, and they behave entirely benignly. This lesion is the other lesion that can look very much like leiomyoma with bizarre nuclei, but it has a different uh, pathogenesis, and it has a fairly significant difference in terms of potential for other neoplasms. So this is a smooth muscle tumor in a fumarate hydratase deficient patient. So this is a fumarate hydratase deficient leiomyoma, which characteristically has these enlarged atypical cells, but it also has oftentimes these sort of eosinophilic inclusions or round bodies in the cytoplasm in various areas. Not in every cell necessarily, but if you look around, you will see them fairly readily in more than one field. Um, so here they are. Now this takes a little bit of practice in identifying these and being sensitive to them. But if you know that you should look for them anytime you see a smooth muscle tumor without mitoses and with nuclear pleomorphism, then I think you'll have a degree of sensitivity that will be invaluable to the patient. Now, why is this important to make this diagnosis? This lesion, this smooth muscle tumor, has an entirely benign course. It doesn't metastasize, it doesn't recur. So, does anyone know why we need to make this diagnosis? Well, the reason is that in patients who have fumarate hydratase deficiency, they are at increased risk of developing renal cell carcinoma. And so if you identify one of these fumarate hydratase deficient smooth muscle tumors, the clinician should immediately uh, look to see, does this patient have a renal tumor? And if not, they need to follow them prospectively to evaluate for that possibility so that it can be detected at an early stage. Additionally, if there are other family members uh, that this may be something that is genetically transmissible. There are sporadic cases, but there also are familial cases where that renal tumor can develop first. And so either doing genetic testing to detect the abnormality or doing some other sort of testing to detect the abnormality will be useful. So how do we prove this aside from doing genetic testing for the fumarate hydratase gene? Well, there is a fairly specific immunohistochemical stain that can be applied to this neoplasm. It is a stain for fumarate hydratase. And in these patients, that stain will be entirely negative. So that is your confirmatory test. Now, you do have to make sure you have a good control and that the control works so that you can be confident that you have not just given the diagnosis on the basis of a false negative. Well, that's 4 or 5 interesting cases to discuss a little bit and think about. And I'll stay on for a minute or two and answer any of your questions if you have them. But I know you have a lot of work to do as well. And I see some of your colleagues already at work. So I won't disrupt too much of your day. And thank you for sharing your cases and listening.
Professor, I have a tumor in uterus, look like leiomyoma with a bizarre nuclear. But the in the morphine, I see the necrosis and some a little metastasis. How to different with liposarcoma? Uh,
So the criteria to differentiate leiomyosarcoma from leiomyoma with bizarre nuclei is mitotic activity,
yeah.
usually greater than 5 millimeters square, and areas of tumor type necrosis. So if you have necrosis or if you have mitotic activity, that immediately should push it out of the category of leiomyoma with bizarre nuclei. And, and usually you can make the diagnosis of leiomyosarcoma based on having 2 of those 3 criteria. If you have all 3, then definitely leiomyosarcoma. But if we see cellularity and atypia along with mitotic activity, even in the absence of necrosis, we will call it leiomyosarcoma, assuming that we have a high enough level of mitoses.
How about immunohistochemistry stain marker is equal to different tumor?
So immunohistochemistry in that situation, some
Yeah,
people will use markers like P53 or P16. I don't think those
yeah.
are definite or definitive because sometimes in these sort of precursor lesions, or sometimes you can have abnormal genetic events without necrosis or so forth.
Mhm.
So I don't use immunohistochemistry in the diagnosis of leiomyosarcoma.
Thank you, Professor.
Okay, good questions. Anyone else? Well, thank you everyone for paying attention and joining me. I'll send a link to these digital slides so that you can look a little further at them if you would like. And I'll look forward to talking with you at the end of this month, at the end of October again, I hope. And we will, of course, be able to communicate in between now and then if needed.
Thank you, Professor.
Thank you. Have a very good day.
Thank you,
Goodbye.
Professor.
Bye, Dr. Ha.